Assalamu alaikum. My name is Dr. Kofahi. I'm staff neurologist at King Abdullah Hospital, and I am assistant professor at Jordan University of Science and Technology. Today, I will be talking about Parkinson's disease and its related disorders. To understand the Parkinson's disease and other movement disorders, we have to understand the anatomy of the basal ganglia. So basically, the basal ganglia are a group of nuclei that seated deeply in the brain in the white matter. The basal ganglia include the caudate nucleus, the putamen, globus pallidus, subthalamic nuclei, and substantia nigra. The globus pallidus divided into globus pallidus externa and globus pallidus interna. Substantia nigra divided into pars compacta and pars reticulata. The basal ganglia mostly involved in the facilitation of the movements, including movements of the trunk, extremities, and the eyes movements. It also plays a role in cognition and emotion.
This is a coronal cut in the brain at the level of the thalamus. As you see, the yellow structure here and here are the thalami bilaterally, which is not part of the basal ganglia. This is the lateral ventricle. Now, the brownish structure here is the caudate nucleus. The light blue here is the putamen. This segment, dark blue, is globus pallidus externa, and this globus pallidus interna. This green or light green structure is the subthalamic nucleus. There's right and left. And this is the substantia nigra in the midbrain. Again, right and left.
Today, I'm also going to talk about hypokinetic disorder, including Parkinson's disease and Parkinson plus syndromes.
To understand Parkinson's disease and other movement disorders, we have to understand the physiology and the pathophysiology of the basal ganglia. In the diagram on this side of the slide or the screen, this is in a normal subject. As you see, this structure is the substantia nigra compacta, which secretes the dopamine. Dopamine exerts effect on the striatum, which is basically a combination of the caudate nucleus and the putamen, through D1 receptor, which is excitatory, and through D2 receptor, which is inhibitory. Now, through D1 receptor, this is the direct pathway, and through D2 receptor, this is the indirect pathway. Now, in the direct pathway, so the dopamine secreted from substantia nigra compacta will stimulate the striatum through D1 receptor. Now, the striatum normally inhibits the globus pallidus interna and substantia nigra reticulata, which in turn inhibit the thalamus. So inhibition of the inhibition is stimulation. So the net effect of the dopamine on the striatum is stimulation of the thalamus, which in turn stimulate the cortex and facilitate movements. Now, in the indirect pathway, the dopamine secreted from substantia nigra compacta will inhibit the striatum through D2 receptor. Now, the striatum will inhibit globus pallidus externa, that inhibits subthalamic nucleus, which stimulates globus pallidus terna and substantia nigra reticulata that inhibits the thalamus. So the net effect again from the indirect pathway is reduction in the inhibition of the thalamus. In other words, stimulation of the thalamus that ultimately will stimulate the cortex and facilitate the movements. In the other diagram here, this is what happens in Parkinson disease. So basically here, there is loss of dopamine from substantia nigra compacta, or reduction dopamine from substantia nigra compacta. So basically, as you see, there is less stimulation of the striatum through D1 receptor and less inhibition of the striatum through D2 receptors. And ultimately, the thalamus will be inhibited more. Again, the thalamus will be inhibited more from the basal ganglia because of the lack of dopamine effect on the striatum, and ultimately will cause inhibition of the cortex and causing the symptoms of bradykinesia and slowing of movements. This is a cross-section of the midbrain. This is the substantia nigra. This is a cross-section of midbrain of a person without Parkinson disease. As you see, this dark brown stain is for dopamine, which is normal. In this diagram, on the other side of the slide, it's a cross-section of the midbrain of a patient with advanced Parkinson disease post-mortem. As you see, there's depletion of the dopamine in the substantia nigra. There's no staining of the dopamine in this area. Now I'm going to go over the definition of some of the terms that we're going to go over in next few slides. Starting with bradykinesia. Brady in Latin means slow and kinesia, motions. So basically it is slow movement. The other thing I'm going to explain is the tone, muscle tone. So the definition of that is muscular resistance that the examiner feels when manipulating a resting joint. So basically when you move, for example, the hand at the wrist joint or the arm at the shoulder joint, when the patient is resting, you feel some resistance, and that's basically the tone. So the resistance you feel to passive movement when the patient is resting. Now the tone can be increased or decreased. The increased tone we call it hypertonia, and the decreased tone we call it hypotonia or flaccidity. Now the increased tone or the hypertonia can be either due to spasticity or due to rigidity. Now the spasticity seen when there is a lesion that affects the corticospinal tract, or the other name for it, the pyramidal tract, due to upper motor neuron lesion that either affect the brain itself or the spinal cord above the anterior horn cell. So for example, stroke or brain hemorrhage or demyelinating disorder or a disc compressing the spinal cord or a demyelinating disorder on the spinal cord, all these conditions can lead to hypertonia in the form of spasticity. The spasticity, it is a clasp knife phenomenon, meaning that, for example, when you're stretching the forearm suddenly at the elbow, you feel at the beginning resistance, then it will yield and let go, so the resistance will decrease. That's typically what we see with the spasticity. On the other hand, rigidity, which is a component of extrapyramidal syndromes, typically due to Parkinson disease or its related disorders. It's rather a lead pipe phenomenon. So you feel the resistance throughout the movement of the extremity, not at the beginning, like seen spasticity. There is another thing we see with the rigidity. When there is superimposed tremor on the rigidity, we call it cogwheel rigidity. So you feel like a cogwheel. Dyskinesias, it's abnormal, uncontrollable, involuntary movements, typically seen in patients with advanced Parkinson disease after long exposure to levodopa. To illustrate the clinical presentation, again, the clinical presentations of patients with Parkinson disease, I'm going to go over a clinical case. So in this case, a 65-year-old male, he noted 2 years ago that there is slowing of his movements in his right arm and right leg. And he also noted that he's shuffling his right leg upon walking. He noted that he has difficulty turning the key in the car ignition with his right hand, and also noted difficulty picking up small objects with his right hand. He also reported difficulty turning in the bed and getting in and out from his car. His wife also noted that he has been shaking his right hand when he is distracted or when his hand at rest. And she also reported that this shaking or tremor in the hand gets better when he is holding his arm up and when he's involved in activities like holding stuff with his right hand. Patient also has been having constipation and decreased smell for some time. His examination showed that he has decreased expressions in his face, or what we call mask face. His exam also showed increased tone or rigidity in the right arm and right leg. And when he is walking, there is decreased swinging in the right arm compared to the left arm. And also, fine motor activity is slow in his right hand. And there is tremor in the right hand when the arm at rest. And the tremor does subside when he holds his right arm up or when he is holding things with his right hand. And you noted that patient is slow in getting up from his chair. Parkinson disease. Definition, it is a progressive movement disorder characterized by bradykinesia or slow movement, resting tremor, which is typically slow 4 to 6 hertz. There's also rigidity, which is a form of hypertonia or increased tone. And there's also loss of postural reflexes that can lead to gait difficulty and falls. Parkinson's disease is more common in males, and the prevalence depends on the age. For example, in this cohort, the prevalence is about 41 per 100,000 in the age group from 40 to 49. However, the prevalence increased dramatically in the age group above 80, where about 2% of population above age 80 will have this disorder. Now, for a patient to be diagnosed with Parkinson's disease, he or she should have certain criteria to be diagnosed with this disorder. One of most adopted criteria are the United Kingdom Parkinson's Disease Society Brain Banks criteria. So for the patient to have Parkinson's disease, he or she should have the cardinal feature, which is bradykinesia or the slow movements. So every patient with Parkinson's disease should have bradykinesia. With the bradykinesia, patient should have at least one of three major criteria, either resting tremor or rigidity or postural instability. So bradykinesia with tremor, patient will meet the major criteria. Now, in addition to that, patient should have at least three of more or less minor criteria. These include unilateral onset. Typically, patients with Parkinson's disease present with bradykinesia and rigidity in one side of the body. Patient should have also resting tremor. The disease progress over time, and there is persistent asymmetry. So as the disease progresses, it maintains asymmetry. So let's assume the patient started to exhibit the symptoms in his right side, including arm and leg. Let's say a few years later, the disease will involve both sides of the body, yet the right side that was affected first will exhibit more symptoms like bradykinesia and rigidity. So it will maintain the asymmetry. Response to levodopa. Patients with Parkinson's disease or idiopathic Parkinson's disease typically respond well to levodopa, which is one of the medications we're going to talk more about later on. Levodopa-induced dyskinesia, we're going to talk about this later on in the treatment, and or clinical course of 10 or more years. Other features that can be seen in Parkinson's disease include micrographia or small handwriting, hypophonia, meaning decrease the volume of the voice, hypomimia or decreased facial expressions, or other name for it, masked face. So you cannot read their face whether they are angry or happy or scared. Hyposomnia or anosmia, meaning decrease or loss of smell, decreased blinking frequency. There's also loss of postural reflexes, as we mentioned before, that can lead to falling. However, this does not happen early in the disease, typically occur 8 to 10 years after the onset of the disease. Now, if it happens early in the disease, rethink your diagnosis. So probably we're not dealing with Parkinson's disease. We are dealing with one of the mimickers of Parkinson's disease if there's early postural instability and falls. The tremor in Parkinson's disease is slow to moderate in frequency, typically 4 to 6 Hz. It is distal, not proximal in the extremities. It's like pill rolling. Pill rolling means like if you have a tablet of medicine or capsule of medicine in your hand between the index finger and the thumb, and you're rolling it. That's pill rolling tremor. It is resting and improves or disappears with purposeful function. The tremor can involve the hands or legs or head region or lips or chin and jaw, and less often the neck. Freezing can happen in advanced disease and can lead to falls. Other features that can be seen in Parkinson's disease, non-motor features include constipation, which can be early on and can precede the diagnosis of Parkinson's disease. Shoulder pain or pain related to dystonia, non-specific sensory symptoms, again, non-specific sensory symptoms like paresthesias, urinary frequency or urgency and nocturia can be seen also due to detrusor hyperreflexia. Orthostatic hypotension can be seen. However, the orthostatic hypotension or other autonomic features typically seen later in the disease course, not early on. If it's seen early on, then we are not dealing with idiopathic Parkinson's disease. We're dealing with one of the mimickers, specifically multisystem atrophy. We're going to talk more about that later on. Another non-motor feature of Parkinson's disease is REM sleep behavioral disorder. REM sleep stands for rapid eye movement sleep, which comprise about 20 to 25% of total sleep time. typically happens more in the second half of the night. And during REM sleep, most of our dreams occur. Now, as protective mechanism during REM sleep, there's loss of muscle tone. We call it atonia, which is a kind of protective mechanism so you do not act out your dreams. So if somebody is chasing you with a knife, you're not gonna flee and get out of the bed and fall and injure yourself. So this is good, of course, to have this atonia during REM sleep. Unfortunately, this atonia or loss of muscle tone is lost in patients with, again, is lost sometimes in patients with Parkinson disease and other degenerative brain disorders like synchronopathies, which unfortunately leads to a patient moving and sometimes screaming in sleep and sometimes getting out of bed while they are asleep and injuring themselves. Other neuropsychiatric symptoms can be seen like depression, anxiety, and panic attacks. Cognitive impairment and dementia can also occur in Parkinson's disease, however, typically starts several years after the onset of the Parkinson's disease. Now we have to differentiate between Lewy body disease and Parkinson's disease with dementia, or idiopathic Parkinson's disease with dementia. In Lewy body disease, the cognitive impairment starts at the same time with other Parkinsonian features like the bradykinesia and rigidity. Whereas Parkinson's disease with dementia, the patient starts with Parkinsonian symptoms like the bradykinesia, rigidity, and the tremor. And the patient must meet the criteria for idiopathic Parkinson's disease for at least 1 year prior to the onset of dementia. Now, the dementia that happens in Parkinson's disease due to involvement of the cortex with Lewy bodies or due to concurrent Alzheimer pathology in the brain. Now, most of the cases of Parkinson's disease are idiopathic. There is no familial cause. However, minority are due to identifiable gene mutation. In these familial cases of Parkinson's disease, the patient is typically less than 50 years old. There has been several loci isolated for familial Parkinson's disease, including but not limited to alpha-synuclein, again alpha-synuclein missense mutation, PARK1, or multiplications, PARK4. Parkin gene mutations, PARK2, leucine-rich repeat kinase 2 mutations, and as mentioned earlier, these familial cases of Parkinson's disease typically affect the younger population, typically below 50 years of age. Now I'm going to talk about treatment of Parkinson's disease. One of the first introduced medicine is the levodopa. And levodopa is basically a precursor for dopamine. So basically it's broken down by the enzyme dopa decarboxylase to become dopamine that exerts its effect on the basal ganglia and replace the missing dopamine. However, when levodopa is given alone, a significant portion of it will be broken down by the enzyme dopa decarboxylase in the systemic circulation before it reaches the brain. So it becomes less effective and can cause more side effects. For that reason, levodopa is combined with a protein called carbidopa. So now we have the medicine called levodopa-carbidopa. The brand name that was first introduced was called Sinemet. Now, this can be given, and the carbidopa will protect the levodopa from decarboxylation in the systemic circulation until it reaches the brain. Then it will let go, and then the levodopa will be broken down by the dopa decarboxylase and be converted to dopamine. The main side effects of this medicine, including nausea, dizziness, and dyskinesias. These dyskinesias are uncontrollable movements that typically start to appear years after exposure to the levodopa. So this carbidopa levodopa, when it started, you see a significant improvement in the patient's symptoms. It has robust effect. Unfortunately, this effect does not last long. So at the beginning, we have this honeymoon period where the medicine is effective, and the effect lasts 4 to 6 hours, so it can be dosed about 3 times a day. Several years later, unfortunately, it loses its efficacy. So you have to dose it more frequently for a shorter efficacy, and we need to increase the dose. And unfortunately, several years after the initiation of this treatment, a significant portion of patients will start experiencing these unwanted dyskinesias at the peak effect of the medicine when it's working. And then we run into what we call the motor fluctuations and motor complications. And these typically seen several years after the initiation of levodopa. That include what we call on and off phenomenon. So when the medicine is given, the patient will become in the on stage where the medicine is effective and patient can move, but that does not last long, and quickly patient will go in the off stage where patient is stiff and rigid with significant bradykinesia and cannot move. We see this more when the medicine is started in the relatively young population. This is why there is a point of view of not using it or not using this medicine in younger age groups. Now, we have other classes of medication that can be used in Parkinson's disease, including dopamine agonist. First one was bromocriptine. We have others like cabergoline, but no longer we use these because of the side effects. And mostly what used now is the pramipixole, which is available in Jordan. There are others like roperinol, which is not available in Jordan. These medications work mainly on D2 and D3 receptors. Main side effects of this class of medications include impulse control, sedation, and hallucinations, especially in the elderly. Another class of medications is the monoamine oxidase type 2, monoamine oxidase type B inhibitors, like seragilin and razagilin. And these medications have modest effect, not robust effect like levodopa, but they are well tolerated and they have minimal side effects, including orthostatic hypotension and headache. So in mild cases of Parkinson's disease, it could be a good option to start with. Another class of medication, the catechol or methyltransferase inhibitors, the COMT inhibitors, like the entacapone. These medications typically exert an effect when it's combined with levodopa. So it potentiates the effect of levodopa by about 25 to 30%. Again, it potentiates, increase the effect of levodopa by about 25 to 30%. So there's a brand name called Stalevo that combines entacapone with carbidopa levodopa and gives more effect than carbidopa levodopa alone. Another class of medications, the anticholinergic medications like trihexyphenidyl or Artane, one of the generic names. Mostly it's helpful for the tremor. We don't use the anticholinergics nowadays a lot because of the side effects, like cognitive dysfunction, especially in the elderly, constipation, urinary retention, and blurred vision. Another medicine can be used, amantadine, that has a modest effect on Parkinson's disease. Again, side effects profile is not bad. Some of the side effects like hallucinations, especially in the elderly. So generally speaking, when to start and what to start treatment for Parkinson's disease depends on many factors. One of them is how bad is the disease. So if the symptoms are mild, we might wait until the symptoms are impairing the patient's function. So once the symptoms of Parkinson's disease, including especially the bradykinesia and rigidity and stiffness, impairs the patient function, then we start medications. Now, if the symptoms are mild, a good option would be to start monoamine oxidase inhibitors like sertraline or rasertraline, or amantadine, or one of the dopamine agonists like pramipixole, especially in young population. Now, in the elderly, typically we start with levodopa, carbidopa, because it has the most robust effect and most efficacious. Now, in younger population, typically we try to delay the use of levodopa, carbidopa, again because of the motor complications and dyskinesias that seen more with this medicine. Lately, the advance in the treatment of Parkinson's disease has been using devices like the deep brain stimulator. Basically, this is a small chip inserted deep in the brain in the subthalamic nucleus or the globus pallidus interna. The chip is connected through wires that exit the brain and the skull and inserted under the skin until it reaches a battery inserted under the skin, typically in the left side of the chest, that gives intermittent electric stimulation. This device is by no means is first-line treatment for idiopathic Parkinson's disease. Typically, it's preserved for advanced Parkinson patients who have good response to levodopa, but they have the motor fluctuations and dyskinesias that typically seen in these patients after long exposure to carbidopa levodopa. This device can cause side effects and complications, including cognitive impairment. Now let's shift gear and talk about a group of disorders that can mimic Parkinson's disease. This group is called Parkinson plus syndrome. So basically they have Parkinsonian features in addition to other features. There are several disorders, including progressive supranuclear palsy, multisystem atrophy, cortical basal degeneration, Lewy body disease or dementia with Lewy body, and others. I'm going to go over a few of these briefly to explain to you that not all rigidities or bradykinesias are Parkinson's disease. So this disorder, progressive supranuclear palsy, is typically start in the 7th decade of life. The main problem here is gait and balance problems that start early in the disease. Now, in idiopathic Parkinson disease, the gait difficulty and the postural instability typically starts later on in the disease. But in this condition, gait difficulty and fall start from the beginning, in addition to other Parkinsonian features like bradykinesia and rigidity. In this disorder, patient also has restricted vertical gaze. It's one of the key features that we distinguish this disorder from Parkinson disease. They can have other features like neck hyperextension. They might also have cognitive impairment and dementia and personality changes. This disorder poorly responsive to the medication levodopa carbidopa, and it is more or less symmetric. And these two features are common among all Parkinson plus disorders. So they share the poor response to levodopa, and they are less asymmetric and more symmetric. And generally speaking, the prognosis in these disorders are worse than idiopathic Parkinson disease. Another Parkinson plus syndrome is multiple system atrophy. So a patient with this disorder has Parkinsonian features in addition to autonomic features, mainly orthostatic hypotension, urinary incontinence, and impotence. This typically starts in the sixth decade of life, and again is poorly responsive to levodopa. So there are red flags that when you see in a patient with rigidity and bradykinesia or tremor would favor a Parkinson plus syndrome rather than idiopathic Parkinson disease, including early onset of dementia, like in Lewy body disease, early onset of postural instability, like in progressive supranuclear palsy, impaired vertical gaze, again, progressive supranuclear palsy, early autonomic symptoms like multiple system atrophy, and so on. Parkinsonism also can be seen secondary to other diseases. This slide has several of these disorders that can cause secondary Parkinsonism. Most commonly, we see it due to drugs. So we have drug-induced Parkinsonism that's typically symmetric and has rigidity and bradykinesia, and there is less tremor. We see it with medications like antipsychotic medications, especially the typical antipsychotics like haloperidol, but we also see it with newer neuroleptic medications or the atypical antipsychotics like risperidone or abiprazole. Now we see also drug-induced Parkinsonism with antiemetics like metoclopramide. Now, vascular Parkinsonism also can be seen when there are multiple lacunar infarctions in the basal ganglia. Although not every patient with multiple lacunes in the basal ganglia would have Parkinsonian features, but some would. Let's shift gear again and talk about tremor, which is another movement disorder. So I'm going to present a case. So this is a 20 years old male, comes to neurology clinic complaining of tremor in his hands or shaking in his hands. The shaking is worse when he is holding things with his hands or when he's holding his arms up. He spills from a cup when he's holding it. He has difficulty using spoon and knife and so on. He also has difficulty writing. His mother has similar problem that started when she was 30 years old. On examination, he has a normal tone. So basically, he does not have rigidity. Again, he does not have rigidity in both arms and legs. He is quick in getting up from the chair. So he does not have bradykinesia. The tremor noted mainly when he holds his arms up or when he is holding objects with his hands. And the tremor subsides when his arms at rest. Essential tremor. or benign essential tremor. This condition is typically familial. The main problem here is tremor. In contrast to Parkinson's disease, there is typically no bradykinesia or rigidity. The tremor typically bilateral, postural or with activity. So when holding the arms up or when holding stuff or objects with the hands. Typically the tremor is faster, 4 to 10 hertz. It can involve the limbs or the head or chin or lips or tongue or even the voice. It is familial. A significant portion of patients would report family history. Has autosomal dominant inheritance. Polymorphism in the LINGO1 gene has been identified in this condition. The tremor in this condition may improve with alcohol intake. That can help with the diagnosis. And the tremor subsides or disappear in sleep. Mild cases of this condition does not need to be treated. However, if the tremor is significant enough that affects the patient function, then it should be treated. Can be treated with medications like propranolol, which is a beta blocker, or primidone, which is an old anti-epileptic medicine that rarely used now for epilepsy due to presence of much better medications for epilepsy, but still used for tremor. Unfortunately, it's not available in Jordan. Topiramate, another medicine, can be used for tremor treatment, which used mostly for epilepsy or migraine prevention. Another medicine can be used, including gabapentin and benzodiazepines. Deep brain stimulator may be used for severe cases not responding to medical therapy. This cartoon shows how the essential tremor can affect the function. In this table, we can see the features that distinguish essential tremor from Parkinson disease tremor. So the type in the essential tremor, it's action or postural, so with activity, whereas in Parkinson disease, it is resting and pill rolling. It is faster in essential tremor, 4 to 10 hertz, whereas in Parkinson disease, anywhere from 3 to 6 hertz. Mostly in the range 4 to 6 hertz in Parkinson disease. Age of onset can be any in the essential tremor. However, Parkinson tremor typically in the middle age or elderly. Typically, there's family history in the essential tremor, first degree relative, but not in the Parkinsonian tremor. Body part in the essential tremor can involve the hands, head, and voice. However, in Parkinsonian tremor, mostly involves the hands and legs. The symmetry, usually symmetric onset in essential tremor, whereas in Parkinsonian tremor, typically asymmetric and slow. The course in essential tremor, stable or slowly progressive. However, in Parkinsonian tremor, progressive, proximal as it generalized to both sides, associated with other features like rigidity, bradykinesia, fixed posture, balance problems, and so on. And you can go over the rest of the features in the table. Physiologic tremor can present normally in many subjects. Typically, it's fast, about 8 to 12 hertz, so about 8 to 12 cycles per second. Can be exacerbated with stress, so you see more of this tremor with stress or fatigue or with fear. You can also see it more with hypoglycemia, hypothermia, excess thyroxine that we see with thyrotoxicosis, pheochromocytoma, drug withdrawal like withdrawal from benzodiazepines, alcohol intoxication, and beta receptor agonists. Finally, I'm going to talk about rubral tremor, which is a rare form of tremor. It's typically low frequency tremor, typically seen with lesions in the dentate nucleus and the brainstem or the superior cerebellar peduncle, mostly seen in patients with multiple sclerosis. I will end up here. I hope this lecture was helpful. If you have any questions, please email me at rmkofahi@just.edu.jo. Thank you.